Wonderful. Thank you, Steve. So as everybody starts to tune in, I just want to thank you for spending your Tuesday evening with us. We have a really unique and distinguished panel of revision shoulder arthroplasty experts. I'm really excited to sort of learn from them, as I know many of you are as well. So as you know, and as you are probably anticipating, Doctors Itamura, Iannotti, Nicholson, and Williams are all going to be joining us, along with Grant Gergus, all five who are some of our world leaders in some of the more complex aspects of shoulder surgery, particularly revision arthroplasty. So we're really lucky to join this. Chris and I know I've been really excited about this journal club. I'm really excited to sort of learn from these really thought leaders and world experts. So I'd like to thank you all for tuning in. I'm going to turn it over to Dr. Klifto. But before I do that, please, I want to encourage anybody who has questions or comments, please chime in either through the question and answer section or the chat. We will get them answered. Dr. Klifto, throughout the presentation, is going to be encouraging discussion from you, and we'll make sure all of your questions get addressed.
Yeah, please, like Eric said, please send questions in. Dr. Geraldi wanted to relay a message that he wanted this to be more challenging questions to the panelists. So let's grill the experts here today. All right, so the first one is Dr. Frankel's study looking at preoperative planning, anatomics to reverses. So this was a single center study analyzing anatomics to reverses. It was a retrospective review where radiographs of 165 revisions were evaluated for loosening instability. There were 79 intraoperative videos, which evaluated component stability, rotator cuff integrity, and glenoid bone loss. Of the explanted components, they were evaluated for wear patterns and backside cement. So of the 79 glenoid components that were revised, 47 showed radiographic loosening compared to 30, which were actually loose intraoperatively with a 40% false positive. There were 32 radiographically fixed components, but only 26 of the 32 were actually fixed, showing a 70% false negative value. So of the radiographically fixed components, 77 had mild to moderate bone loss, which was interesting. So the loose glenoids had a higher rates of synovitis and glenoid bone loss in the study. The rotator cuff deficient patients were associated with posterior and anterior displacement, and then glenoid loosening correlated with displacement as well. Of the explanted components, they were predominantly had eccentric wear patterns. And this was done radiographically and with clinical assessment. So the study concluded that evaluation of revisions from TSAs to reverses correlating with the ability to look at radiographs for predicted intraoperative implant stability and cuff integrity. They evaluated radiographic evaluations of glenoid loosening was not always accurate. They found displacement correlated with cuff integrity. They found that synovitis and glenoid bone loss correlated with loosening, and asymmetric wear potentially altered the pathomechanics. So for Dr. Williams, how do you anticipate the ultimate glenoid bone stock available via the preoperative workup? And are there tips to better predict cases of massive or uncontained bone loss?
Well, I think Mark's point of finding massive bone loss or erosion and basically erosion around the glenoid component is a big help. But if you don't see that, it's not as much of a big help. And I also find CT scans, particularly with dye, sometimes to be helpful. I also find that the cause of the revision and the length from implantation can be helpful. For example, if it's instability from a subscap failure relatively early, you're not going to find much bone loss, and that'll be a relatively easy component extraction and revision. And if it's somebody that I put in a glenoid component 20 years ago, and they got all kinds of osteolysis around the component, I know that the component's going to come out with my fingers, and there's going to be a hole the size of the Grand Canyon in it, and going to be much more difficult. So I think they're all pieces of the puzzle from my perspective. But I would add that, at least in my hand, CT scan with contrast can sometimes be very helpful.
That's fantastic. Dr. Anna, can you expand upon that? How do you use CTs both to sort of evaluate that maybe loosening, and then even maybe more importantly to evaluate what you're going to get to when you actually revise that component? What's the bone stock? What's the potential bone loss that you're going to be dealing with?
Well, I guess the first comment I would make is that I think the premise of this paper is a little bit suspect. I think we have to be careful about using a definition of loose, meaning it's loose because you can pull it out with your fingers versus it required an instrument to remove, because certainly from a pain perspective and from a failure of the implant, you could have an implant that's loose radiographically, but still requires some kind of instrumentation to remove it. So I guess you can say that there are implants that are grossly loose and there are implants that are loose. But my sense is that you have to be careful about saying that there's a 40% error rate because it couldn't be removed with your fingers. From a patient's perspective, in terms of generation of pain or reason for failure, you can have implants that are loose with a complete radiolucent line that requires some effort to remove it at the time of surgery. Particularly implants that have fins or other kinds of features where there's soft tissue that is within the features of the implant. Those are not all so grossly loose. Relevant to your other question, which is probably the more important question, the CT scan depends on the quality of the CT. I mean, I think if you got good quality x-rays and you have serial x-rays over time, you can certainly understand the difference between implant that's appears to be loose. There's a complete lucent line that is progressive over time. So I think, again, a CT, I think, helps you define the amount of bone loss you expect to see, especially if you have a metal artifact reduction CT. And then there's the issue of implant shift, which, again, with complete radiolucency is another way to understand how much bone loss you're going to have. Now, we published a paper very recently that looked at serial CT scans that were done with metal artifact reduction and showed that shift of the implant is not always correlated with loosening, which was a surprising finding because I always expected that shift was correlated with loosening. But you can have shift, and in our paper, we had 4 glenoids out of 170 that had serial CTs that had double-digit shift, like 10, 15 degrees of implant shift without any evidence of loosening. Matter of fact, there was full integration of the central fin with bone. And I'm not sure I can explain that. I make an analogy that, if you go to an orthodontist and you want your teeth straightened or moved, or you get Invisalign, you can move your teeth. If you do it in a proper way, that doesn't mean to say your teeth are going to be loose. So again, it depends on the rate of movement and the timing of movement that bone can remodel around a shifted implant. So I think the cardinal feature of loosening is really the bone reaction around the implant, meaning that you have osteolysis around the implant. And I guess the other thing I would say is that, at least in my experience, that there is many years, single-digit years, between what looks like radiographic loosening and implant failure, meaning symptoms that justify revision surgery. So unlike knee and hip arthroplasty, I think you can have a long period of time between clinical failure and radiographic failure.
We have a great question from Michael Goshak. How many of the panelists are doing arthroscopic biopsies and evaluation prior to formal revisions?
Talking about for infection?
Yes.
Well, I don't use it for aseptic loosening. I typically use it when I have a painful shoulder that doesn't have reasons for revision, meaning the implant is in good position. It doesn't appear to be loose. There wouldn't be a good reason for revision for aseptic loosening, but the initial workup for infection is negative. Or I think I may retain an implant. I may not take everything out. And my concern about being sure it's not occult infection is a reason for biopsy. So they're very specific indications for arthroscopic biopsy to rule out infection.
I would agree with Joe. It represents probably 10% or less of my revisions.
Yeah, it's not something I have used routinely at all. It raises the cost of the episode of care over $20,000, right? It's still an anesthetic. It's still an operation. I don't like the material I get. You know, you want to have 5 localized biopsies and you get in there, there's a little synovitis and you've got a grasper and you're pulling out snot that doesn't, you know, you send it to the lab. Yeah, it's a tissue culture. And I agree with Joe and Jerry. It is for the conundrum. You don't have lucency, you don't have stiffness, you don't have lysis anywhere, and you're not ready to revise that implant. That's pretty rare in my practice, actually. I think it's something to have in your armamentarium, but I would not like to see us go down the road of that's how we diagnose infection. Let's do an arthroscopic biopsy. So it hasn't been a big part of my practice.
Perfect.
I think I think there's a point to be made relevant to the technique. You know, I'm not sure that anybody has standardized what biopsy, arthroscopic biopsy means in terms of the surgical technique and how many biopsies you should take and the number of biopsies versus the accuracy, true positive versus false positive or sensitivity specificity. So I think that's an unanswered question. When I do biopsies, I actually do use a fairly large punch biopsy. I do get capsular tissue and I usually aggregate 3 to 5 samples from 3 or 4 quadrants. So at the end of the day, you're taking about 15 to 20 samples. I aggregate them so that I have an odd number of cultures sent, but not one piece from each area. So I do think it's important to think about saying, well, if it's worth your time and effort and the expense of doing arthroscopic biopsy for infection, that you really should take a fair number of samples, because you do get sampling error if you just take a few tiny pieces of tissue.
Yeah.
But, you know, we had our international consensus meeting for periprosthetic infection, and that's exactly as Joe Iannotti said. One of the recommendations was to take your samples through a cannula so you don't have skin contamination on the way out, in and out. Use clean instruments. And as far as where to do, I think people want to do something that's, you know, in continuity with the joint space. So synovium, typically there's some synovium you can find. The thing is, you know, this best available data we have, it's 10, 15% maybe of those will be positive, even when there's no evidence of infection. And those are often deemed false positive, although it's a murky subject that we don't necessarily want to get into. But the point is I use that as a last resort anyway. And then unfortunately, that can cloud the diagnosis even further. So it's certainly not something you want to have, in my opinion, as your first go-to. When evaluating a painful shoulder arthroplasty, you want to look for infection with a standard test or loosening or cuff failure, et cetera, because it's not necessarily going to give you the answers that are going to guide your treatment.
Grant, maybe you and Dr. Itamura can elaborate on that. We got a question from Brian Lee. What is the panel doing for their initial infection workup at this time?
John, you want to take that one?
Sure. Hi guys. So my initial workup is labs. So I mean, I get CRP, sed rate, CBC. I usually try to aspirate in the office, although it's not always that fruitful. But if I get some fluid, I'll send it for synovusure. I typically check prealbumin, and that's pretty much what I do. To go back on the arthroscopic biopsies, I actually don't do those a lot either. But the other thing that can help you, and the ones that that you think are well fixed, there's a, I think at least in my practice, about 25% of the glenoids are loose. So you can take those out arthroscopically. And some of those patients, I don't think they do great, but they don't want to, for some reason, people don't want reverses sometimes when they have a standard arthroplasty. So I can take out the glenoid arthroscopically and get more biopsies underneath the glenoid too.
One point on the on that, piggybacking on that and going back to what we talked about earlier about how loose is it, how much glenoid bone loss do you have? A trick Jerry Williams did many times is occasionally have these glenoids that they're a little bit loose, but maybe the central peg has growth around it or whatever. I think, Jerry, you showed me many times, if part of that glenoid is stable, don't worry about digging every last bit of polyethylene and cement out of the glenoid vault, or you're going to have nothing to work with. You would always take a cob and just sever it off, and the pegs that came out, and the ones that were well fixed, you'd put the implant right through it. I always thought that was a great trick. I don't know if you're still doing it that way, but I found that helpful.
I came to that technique the hard way. I basically just figured, I got sick of digging stuff out and having huge holes. So basically I took out the articular surface, put in my guide pin, prepped the glenoid, and whatever came out when I reamed it, I took out, and what stayed in, stayed in. And I've been doing that way for decades.
Awesome.
I've done the same. I think you have some of these anchor peg or other kinds of implants, if it's not infected and it's solid, depending again on what kind of reverse base plate you use, but it's not uncommon that you can work around them and not dig them out. Again, you got to be sure it's not infected.
That's awesome. That's awesome. Fantastic. All right. Well, just in the nick of time, or in the consideration for time, we're going to move on to the next one. So this is Dr. Nicholson, Dr. Garrigus' study on conversion of TSA to RSA. It's a study that covered a 12-year period, 75 patients. The time between reverse, or the anatomic and reverse, was 4 years. In general, as you can see in table 1, the indications varied, but many of them had multiple indications, including painful arthroplasty, rotator cuff failure, and stable arthroplasty. Many of the ones that we were just talking about. Overall follow-up was 22 months. And you can see in general, patient-reported outcome measures were improved, but not as good as many of the primary reverses achieved, as you can imagine. And interesting enough, external rotation did not significantly improve. Complication rate overall was 28%, with 11% being major complications. The major complications being dislocation, infections, and glenosphere displacement. And the overall reoperation rate was 12%. So, an interesting convertible stents did not have an impact on ultimate outcomes. So this is a really phenomenal study, a long study period, comprehensive postoperative data in the revision setting, something that we don't have a lot of, and sort of confirm the clinical outcomes in this revision setting are going to be worse, particularly when you're revising something like an anatomic that has a glenoid component. It also demonstrates the difficulty associated with these, particularly compared to some of the other studies looking at revising hemis to reverses. So it's a really great foundation in this sort of complex patient cohort. So Dr. Nicholson, if I could start with you, if you don't mind.
Sure.
So sort of what did you learn about this study? It's a long study period, obviously, when you're revising anatomic to reverse. Maybe things that you take away that you do now that were differently maybe than earlier in the study, or something that you would tell your fellows when they're taking on these challenging patients?
I think one of the things that was, I guess, somewhat disappointing is the interval from the index procedure, the total shoulder, to the need for revision. It's only 4 years. An anatomic shoulder lasting 4 years is not a great result in any stretch of the imagination. Obviously, there's also a little bit of confusion. Okay, they have a painful shoulder, 87 or 92% had painful shoulders. But if you got rotator cuff failure or loosening or stiffness, or you're going to have a painful shoulder. So the infection rate, I believe, in this was about 20%. As time went on through the study, obviously our advanced imaging got more sophisticated. And I think Joe and Jerry had mentioned it earlier. Starting out, you'd probably get like a CT or 2D CT and say, okay, hey, can you give me some subtraction techniques? Now we can do a lot more. A CT arthrogram gives you tremendous information on, is the subscap intact? Is there dye leaking behind the glenoid component? A lot of these things that lead you to your strategy for revision to reverse. But as you saw in the first paper, Mark Frankel's paper, which, and I agree with Joe Iannotti, there are some methodologic things there that I don't think you can hang your hat on to those numbers as strongly, but it shows you what you see on X-ray may not be what you see intraoperatively. So I guess what we've learned is, number one, it is successful to re-implant a reverse in an anatomic shoulder environment. Number two, you must expect the unexpected and have plan A, plan B in the room and plan C in the hall. And with the advent of more revision-like or augmented or variety of fixation base plates over the last 3 to 5 years, I think revision of an anatomic with a glenoid defect, be it contained or mildly non-contained, we can do a better job implanting that base plate in the right position. We'll hear from Joe's paper about bone grafting, but I think it shows you, I mean, look, the average active forward elevation in the revision series was about 128 degrees. So good, but nothing's ever as good as the first time, right? So I think it gives us a framework to work forward. And I think what would be interesting is if you compared revision of anatomic to reverse, revision of failed reverse to reverse, that anatomic to reverse is probably a better result.
Yeah, I can imagine. I can
A
imagine.
question from John Haverstock. Does the panel have a specific criteria for diagnosing infection based on open biopsies at the time of revision?
So open biopsy at the time of revision, we're assuming we take 5 tissue samples. I think if something grows out in 2 out of the 5 in less than 7 days, that's infected. And obviously we're probably talking about C. acnes, but I think the faster something becomes positive and the more number become positive, the more you are assured that yes, you are dealing with an infection.
Grant, do you want to both comment on the question about the how to diagnose infection at the time of revision, as well as maybe cover or piggyback off what Dr. Nicholson said on sort of how do you think we can sort of or what are some things that you would advise your fellows on optimizing these outcomes in this anatomic to reverse revision?
Yeah, so with regard to the infection question, it's a great question. The sort of best available condensation of the evidence we have as part of the international consensus meeting, Delphi, that's freely available online. And basically, we proposed a definition and some different criteria you can look at. The bottom line is that there's no widely available preoperative or intraoperative test that can reliably detect the presence of infection or absence of infection in a shoulder arthroplasty. So ESR, CRP, white counts, physical exam tests like fevers, chills, redness, drainage, none of that stuff is predictive because C. acnes has such a low virulence. Frozen sections have been shown to not always be helpful. Aspiration is 50% as a dry tap, on and on and on. The gold standard is the cultures. About 15% of those are false positive. And by false positive, I mean air swabs at Rothman, about 18% grew out C. acnes. Gauze sponges put directly in the thing at Duke, about 18%. Again, it's about 1 out of 5. So just like Greg said, if you have 2 out of 5 for a low virulence organism, that's maybe more popular or maybe more predictive. But we use that ICM criteria. There's a scoring scale as well. Joe Iannotti won the NEAR Award for some cytokine things and some lab tests that may help our predictive nature. He also looked at exactly as Greg said, how quickly the cultures grow out. So if it's day 14 in the broth only, that's a lot different than day 2 in 4 of the 5 samples. So Joe, I'd love to hear your thoughts. I know you and the Cleveland Clinic Lab have done a lot of the research that we use to make our recommendations.
Yeah, I think your comments are spot on. I don't think you can hang your hat on any one set of criteria. I think if you have a low suspicion for infection and you get this 1 out of 5 cultures that are positive, and it takes a long time for it to grow out, and if you took a synovial fluid sample and you sent it for some kind of cytokine response and it was positive, then, you know, it might be more likely to be an infection. So again, I think unfortunately there is no, unless you got a sinus tract and it grows out staph and, you know, it's the rare occasion. But if you've got the typical shoulder arthroplasty where there's some component loosening and they have shoulder pain, you know, it's if you have multiple cultures and only one grows out positive at double-digit days, it's probably not infected. So unfortunately, you've got to use multiple criteria. And the question always becomes in either a 1 or 2 stage revision, is your suspicion high enough to treat the patient? I mean, that's really what it gets down to. I mean, it's an academic question. If you said, well, was it infected or not? The real question is, are you going to treat it? And are you going to treat it for X number of weeks with IV antibiotics when you know you're in this middle zone or gray zone for possible infection? That's the hard question. It's the rest of it's a semantic argument. Because there are some people who say, yeah, I was infected, but I did a great clean out. I'm not going to treat it with antibiotics. And other people will say, if one culture came back positive, I'm going to treat it with IV antibiotics. So it's a real problem, not just in classification, but it's in terms of us having a consensus around what do you do with the cultures that are positive. And there's no agreement in that regard in terms of how to treat it, how long, do you do IV, do you just do orals, do you do oral suppressives for 6 months, 9 months, a year, lifetime? So there are a lot of unanswered questions.
That's a great segue from Ben Sharia. He said, is anyone on the panel routinely placing patients on a course of postoperative PO antibiotics following a revision to arthroplasty, even if the suspicion is low?
I do.
So do I. I give them 2 weeks of doxycycline till the cultures come back. The other point that I wanted to make that I learned the hard way, I think when you get to the point where you've got enough of a suspicion to at least think about having the patient get treated post revision for their positive cultures, I think you need, for me, I like to do 2 things. I like to involve an infectious disease person to get their input, and I like to make it shared decision-making with the patient, because I have a patient that was about midway through my career that I revised what looked like a routine aseptic loosening component of mine that was about 15 years out. Guy's cultures were positive. I told him he needed to be treated with a PICC line. He lived up in Scranton, which is about 4 hours away from me. His arm that had the PICC line swelled up, they thought it had a clot in it, so they moved it to his operative arm and put him on some sort of anticoagulant. He fell at home, hit his head, and died. And I got a phone call from his wife saying to me, and she never sued me, which I don't really understand why. But she said to me, Dr. Williams, I can't help thinking that my husband died treating something that he didn't even have. So what that said to me in the very mid portion of my career was, I was out of the business of telling patients that they should get treated for cultures in their revisions. At least I wasn't going to be the person taking the bullet. I was going to get some input from the infectious disease person and have a very frank conversation with the family so that they can make up their mind what they would like to do.
Fascinating.
I think those are great points, Jerry. I do the same thing. I send patients home in 3 weeks of doxy, and I have been getting the ID people involved, especially when they get 2 positive cultures of Cutibacterium. So I think it's just, I remember you said that at one time, and I kind of took that to heart. So I involve ID too.
Get an ID doctor that's familiar with musculoskeletal infections, because many of them are just as confused as we are, with less experience than us as orthopedic surgeons. So finding a good musculoskeletal ID doc is pretty important. Otherwise, they just add confusion to what is already a difficult decision. And as much as you like to put patients in the sort of joint decision, this is such a confusing topic that most of the time they're going to come to you and say, Doc, I don't understand this. Please tell me what you recommend. It's a tough problem.
Well, I can tell you up until that point in time, I never really realized that that particular complication could occur from treatment of positive cultures
No, sure.
after a revision. And I can tell you that I never forgot it.
Yeah, those experiences change how you think forever. Non-scientific, by the way, but nonetheless, they do change how you think.
Completely emotionally.
I can imagine. Chris, do you want to go to our next one on humeral bone loss, kind of changing gears a bit?
Absolutely. I'll be brief because this discussion is so good. I'll try and go through this quickly. So this was a retrospective study. It was a radiographic study. 6 surgeons collaborated to create a humeral bone loss classification scheme. 2 surgeons classified 108 revisions from 1 center. 1 additional surgeon then repeated these measurements 4 months later. They developed the Pharos classification, which was type 1 loss of the epiphysis or greater tuberosity or calcar. Type 2 was loss of the metaphysis above the deltoid attachment. And type 3 was bone loss below the deltoid attachment. They then subsequently had subtypes based on cortical thinning. They had an intra-relator reliability of 71% and good intra-relator reliability. And then they had a couple tables which showed bone graft or proximal humerus replacements used for type 2 or 3. So in conclusion, this was a novel study on humeral bone loss in the revision setting. It helps to start a unified communication for humeral bone loss amongst surgeons and a simple and relatively reliable classification, which was a great foundation for future studies establishing an algorithm. So Dr. Itamura, what is your approach for type 1 bone loss when the calcar or tuberosities are not present? And do you have any technical tips?
Well, for me, the whole thing is like if I'm revising somebody to not cause tuberosity fractures is I'll typically take a saw and cut off some of the proximal bone so I can kind of dig under the calcar. And I think it's, iatrogenic tuberosity fractures are actually pretty common. I've gone to trying to revise the glenoid first. So I think if you take out your humeral implant and you're kind of screwing around the glenoid and you retract it, you can break your tuberosity pretty easily. And so for me, unless there's a male taper, which makes it difficult, I will try to, I think number one, go to the glenoid first. I think there's a couple factors involved on, whether you're more likely to have one. And the ones with the kind of the overhanging, where your tuberosities are close, those are the ones where you have to be really careful. And I'll take a saw and so I can actually see the implant and really carefully try to get around the prosthesis. And I'll always take about 1 centimeter of bone so I can actually get there. Because I'd rather take 1 centimeter of the bone than blowing up the whole thing and just be slow. I mean, I think using a combination of some of the Moreland instruments, both curved and straight, and just taking your time and tapping. And I think that the whole thing is really look to see where your porous coating is, look for things like fins, close pinning, and you need lots of different things. I mean, I think if you use a standard osteotomes, that's guaranteed to break to your humerus. So I think having whatever Shukla or Moreland instruments that are thin, I'll usually start with like a 2 millimeter drill bit so I can really get right along the prosthesis. And I don't really care if I break them because they're nice and they're small. And then just being patient. But I think the other thing is if I have somebody with a 2A or 3A bone loss, they're and like a Zimmer stem that has really good fill. Those are patients that I'm probably going to go quickly to an episiotomy. So I think what I've learned in the last 27 years and a billion F-ups when I'm revising is the ones you think you're going to get out that you don't think about when you look at there's a really good fit and a lot of bone loss, like a 2A or 3A bone loss. Those are the ones when you're trying to chip them out, you're going to break them. So those are the ones, at least in my mind, I'll go to a quick episiotomy. And at least if I see a greater tuberosity fracture starting, Jerry told me just to put a little stitch in it and just keep an eye on it. But that seems to help. But kind of prophylactically putting some loops around the tuberosity at the beginning seems to be helpful. But I think for me, the most helpful thing is starting with the glenoid first.
That's awesome. Dr. Nicholson, do you want to expand upon that? So maybe any other tips you have for taking out a stem, and then let's say you do have a intraoperative fracture, be it like a tuberosity fracture, how do you manage it?
Let me go, I'll handle that in a sec. The classification was put together and then tried to look for reliability among surgeons on what they thought the loss was. And then two of the surgeons did cases to see, does it fit radiographically and intraoperatively? Obviously, there's going to be bone loss pre-op, and then there may be bone loss post-op, but we didn't really get into that with that paper. I think the paper gives you a framework to move forward. What we found was if you had the type 1 loss, the greater tuberosity or the calcar loss, where you really got into trouble was length, because you lost your landmarks for length, especially the tuberosity. As John said, you bang out the prosthesis and the greater tuberosity comes flying off with it. That hurts a lot of things. But if let's say it was an old fracture and the tuberosity is way behind the glenoid or something like that, you've lost external rotation power, but you've also lost proximal humeral bone stock to do a muscle transfer, but you've lost length. That's where you probably need scalar films side to side so you don't make a mistake on your revision. And as you go down lower, now you're talking about an APC. And if you go down to type 3, you're probably talking about a proximal humeral replacement or something big. So, as John said, we've all developed tricks not to create from type 1 to type 2 in a heartbeat. Vertical humeral osteotomy. I designed some revision instruments that are smaller and shorter, so we can handle them better up at the top than the giant Moreland. The Moreland, you're like, hitting it from, the sky. But also knowing where the fins are, where the ingrowth material is, getting on the medial calcar, the extraction device that comes commercially with that implant, as we all know, never works. So I think there's a lot of strategies in that. And I think the Pharos classification has not been proven, you know what I mean, in live fire exercises, but I think we all know where the troubles are. And that's why we talk about calcar, greater tuberosity, anything above deltoid tuberosity and then the surgical neck, and then anything below the deltoid tuberosity, you're in trouble. So anything you can do, go slow, vertical humeral osteotomy, hit from below. Also, know your enemy. Know the implant that's in there. Is it one of these things that's roughened all the way down? And you're going to have to go slow or have to really extend so you don't lose more bone. And I think John's point is a great one. Get the glenoid out first before you leave a shell of bone, and then hang on it with a Fukuda, because then you'll lose all your proximal bone. So long-winded, but I wanted to kind of clarify a little bit on the Pharos.
Yeah, no, I appreciate that. So Dr. Iannotti, when you have, let's say, a type 2, so it's right below the deltoid insertion or right above it, or type 3 where it's below, how do you sort of decide how to reconstruct those types of sort of massive or significant bone loss?
Well, I think you have to if I'm assuming you're doing a reverse arthroplasty in this revision, So I think there are two, I guess, three principles. One, save the fragments, even if they don't have a whole lot of structural integrity. Only in that they often have soft tissue attached to them that is important for stability of the implant. If you truly have complete bone loss, then you have to determine how are you going to try to get the stability from deltoid tensioning, lateral deltoid tensioning. And for me, that's when I go to a composite allograft long stem prosthetic. I've gotten into trouble with instability of reverses when there's no greater tuberosity and no wraparound effect for the deltoid. And that's true for both the Grammont style or a lateral offset type reverse arthroplasty. The third principle is, when do you need bone graft to help augment the healing of whatever bone you have left? So I think you can have a stable implant, but have a situation where the bone that you try to save is just not enough of it. And that's where struts or other kinds of allograft play an important role. So, I think the article that was written is actually a good article, in that I think the classification is useful. I think the problem with every classification is that we have human beings that look at them and try to apply a classification, and almost always the inter-rater reliability is poor. I've written, I don't know how many articles, I don't know how many years of my life I've wasted doing, articles where you get people to try to take a classification and apply it among good surgeons that have good judgment. And it's because, they make slightly different interpretations, and you have to bucket it into, type 1, type 2, type 3. And human beings are just not that good at reliably applying a classification. So the bottom line is, I'm not surprised that the inter-rater reliability was not great. I've only seen 1 or 2 articles. I mean, the article that comes to mind where the inter-rater reliability was good is the Walsh classification, when the inter-rater reliability was done by everybody that trained with Walsh and were in the room, and because they all learned how to do it. If we do an inter-rater classification among all the people that we train and are in their fellowship, and we tell them exactly how to classify a B glenoid from a B2 for a B3, you get good inter-rater reliability. As soon as you ask 15 different surgeons who are equally well trained, that you get poor to fair inter-rater reliability. It's not because the classification is bad, it's the application is difficult to apply. So this particular article, I think, is a good classification system, and the inter-rater reliability being sort of fair is just the fact that you've got human beings. That's why I think, AI and some other kind of methodology to standardize, reading x-rays are probably going to be where we go down the road.
Amazing. And then maybe to finish this off. So Dr. Williams, do you want to talk about, once again, when you're, you know that you have some sort of bone loss preoperatively, whether it's the tuberosity or maybe it's a type 2, sort of how you're going in planning this, what's your reconstruction strategies, what's your decision making when you actually get to these settings of when it goes beyond the tuberosity and maybe type 2 or even some of the type 3s.
In the interest of time, I'll just give you 2 points. The first point, and both of these I learned the hard way. The first point is that if you're doing something for fracture where there's a malunion of the tuberosity, and you think that you can mobilize the tuberosity from behind or near behind the glenoid and get it back to the prosthesis and have it work, you're going to be wrong 999 times out of 1,000. That piece of bone needs to be excised so it doesn't dislocate the implant, and then you need to figure out whether you need to get rid of you need to recreate the bone and with what. So I've learned, I don't know, at least 10 times that you can't leave that there. It cannot be left there. So that's the first point. The second point is, I do think that Pascal and Gilles are correct in that length does correlate to instability when you're trying to reconstruct these patients. But the part that I haven't figured out yet is exactly what length number you take, because I can tell you that in every one of these cases that are chronic cases that are shortened and have a certain amount of bone loss that I've measured very accurately with scanograms on both sides, I can never get the size allograft into that patient and get the arm reduced that I measured on the preoperative radiographs. So I think there is a correlation between length and stability, but I think trying to totally recreate the length to exactly what it was, particularly if it's 6 months to a year out, is very, very difficult, if not impossible.
I agree. I mean, we're going to move on to the last study. So this is Dr. Iannotti, Dr. Ricchetti's study on structural versus non-structural bone grafting. A single study over a 9-year period, 30 patients, 15 structural, 15 non-structural. In general, the structural were done for uncontained defects, non-structural were done for contained. The non-structural was allograft compared to autograft structural grafts. So follow-up was great in 2 years. And in general, the structural grafts had 93% partial incorporation. There was 40% partial resorption in them, but overall, no difference whether you used a standard or long peg. There were no differences when you compare the groups between patient-reported outcome measures, the Penn Shoulder Score, the RAND 12 survey. Complication rate was overall 17%. There was 1 revision for base plate failure in a structural autograft, and 2 early shifts in the base plates without ultimate failure. So phenomenal study, great comprehensive clinical and radiographic study. It really helps to show the value of structural grafting in this really complex patients, particularly with these big, massive uncontained defects. So it confirmed that the structural grafts have a role, and maybe started to help continue to lay an algorithm for how to manage glenoid bone loss, particularly as Dr. Nicholson mentioned with some of the recent implant innovations that have really expanded our armamentarium. So Dr. Iannotti, given this your study, maybe do you want to briefly talk to us about anything that I didn't hit on that you think is important for the listeners to take home from this, and maybe your technique for these uncontained defects?
Well, I would say it's an average study. I wouldn't say it's a good study. I think the sample size is small. There's too much variation in surgical technique between standard peg and long peg. So I think the conclusion that we showed no difference is because of sample size and not a standardized way of reconstructing them. I think the only value of the study is that we compared basically the non-structural grafts as a control group. We basically said that if you've got at least 50% backside contact with native bone, you really don't need a structural graft. And so that was our control group. If you said what would have been a really good study, would have been to compare allograft structural graft to autograft structural graft, because I think that question remains unanswered. Is it worth taking somebody's iliac crest for an uncontained defect that you need structural graft for? We didn't have enough of those cases in order to do that comparison. So that's why we ended up doing the non-structural graft as sort of a quote unquote control group. But I guess the only thing I would conclude from the study is that iliac crest graft can work. It does incorporate well enough that you don't see a whole lot of resorption. And surgical technique matters. Even if you got good quality bone and you've got enough of it, you're still going to see some implant failures based on surgical technique, either screw length or fixation. It's a typical retrospective study. It's got all the failures of every retrospective study, including small sample size.
Perfect.
So it wouldn't be among my top 10 papers that I've published in my life. Let's put it that way. Probably not even in the top 100. So it's okay.
Perfect. Dr. Itamura, do you mind touching base or talking more on your sort of algorithm intraoperatively when you're managing bone loss, when you decide structural versus non-structural or allograft versus autograft?
Yeah, I use the same criteria I use for this paper. If I can get 50% or more of the backside of the contact, particularly if it's on the periphery of the thing, meaning you got a small central hole, and you can get screws well past the defect, then I don't think you need a structural graft. And probably doesn't matter if you use autograft or allograft. I think the hard part is when you say I need structural graft material to support the base plate.
Sure.
And again, getting the screws well past the graft is critically important into the native bone. I don't know what's the right answer in terms of allograft versus autograft. I'm not willing personally to do that experiment. So I use iliac crest graft, but there are a fair number of people I suspect on this journal club that use structural allograft, and at least as I've heard them say in the past, it's been successful.
Yes, John Itamura, what is your approach to these either autograft versus autograft, structural versus non-structural? How do you make that decision?
Actually, I don't like using allograft that much, except for the humeral side. If it's a big non-contained defect, I'll put a Proselec in and use titanium. I'll have a VRS made.
What did you do before VRS was available?
Oh, I tried iliac crest. I used humeral. I used allograft, all kind of allograft. And I mean, some worked great, some didn't work great. And I just couldn't stand kind of flipping a coin and say, well, surgery went great. We'll see how you do. And sometimes having a bunch of screws sitting all over the place in the axillary pouch is kind of disconcerting for me.
Dr. Nicholson, do you want to expand? How do you manage some of these big glenoid defects, whether it's graft or metal?
I think contained defects are not easy, but they're certainly easier, right? And almost any glenoid, no matter how bad it's beat up, the inferior rim is almost always there. It'll give you a feel for, okay, how uncontained am I? And that's my reference point. And I agree with John and Joe. I like the periphery. So I'm going to use a bigger base plate, not to fit down inside, but to land on that outer rim that's still there. With the advent of augmented base plates, we can kind of catch up to the edge that's non-contained, but we can lay down on it. If it's contained and big, I'll actually use the allograft croutons, and I'll make my central drill hole, put the drill bit in it, and then I'll crush the allograft to fill the cornucopia of the glenoid up, remove the post, so I still have a hole, and then I put my base plate down on it. If it's a non-contained defect, I agree with John and Itamura. There's nothing worse for me than, and at Rush, we do have these like tricortical allografts, they're iliac crest that the spine guys use. They're available, so you think this is great, because it's a bigger defect than I thought. But for the next 6 months, I don't sleep well because I'm just thinking creeping substitution, and my allograft is melting away and the screws are going to get loose and I'm going to have an x-ray that I don't like. And I agree with Joe, there's just not enough standardized techniques or grafts out there, allograft versus autograft in structural. But if you look at all the studies on structural allograft on the glenoid side, no matter anatomic or reverse, they don't tend to do very well. So I try to get down onto the bone, catch up with lateralization or augmentation behind the base plate, kind of accept what the glenoid gives me to the best of my ability, and then adjust the humerus accordingly.
Dr. Williams, do you want to add anything to how you approach some of these challenging glenoids?
I don't have a lot to add, but I would just say that over my career, I've morphed to almost, I want to say at least 90% of the time using metal. I rarely use a structural graft anymore. Every now and then I do, if it's a really huge defect, but I use metal most of the time. And like John, I like the classification system that was in the article that has to do with peripheral versus central, and then the peripheral ones are symmetric versus asymmetric. The asymmetric wear give you subluxation of the humerus with respect to the glenoid, and those are the ones that in my experience are most difficult to manage. And if they're really asymmetric, then I think a vaulted system like John talked about is useful, and I've used that on several occasions. It's expensive, so I try not to use it all the time, and I find that augmented base plates, sometimes with allograft behind, but most times not, work much better in my hands than a graft. With grafts, I found myself trying to carve a piece of custom furniture every case I did, and I wasn't that good at it, as opposed to an augment where I just have to make the bone fit the augment. It's easier for me, and I find it to be, at least I think theoretically, your weakest fixation in that situation is time 0. If it doesn't get infected, it's probably going to get better with time. So I've gone to metal, and most of the time. I haven't done that on the humerus yet. I don't know why. I guess I'm an idiot. But the bottom line is I've really moved away from autograft or allograft on the glenoid.
Awesome. Grant, anything else you want to add to maybe some technical tips to managing these difficult settings with bone loss?
No, I mean, I think having pre-op imaging is really helpful. I think when you're talking about patient-specific instrumentation, that can be really helpful if you're going to have a hard time finding that very limited bone that you need for secure fixation. If you're doing a 2-stage, that makes it really easy because while I have the antibiotic spacer in there, it's a great time to see the extent of what bone was removed during the primary arthroplasty if I thought this was infected. And then often I'll have kind of a guide made. I think really getting that good fixation is nice because if you have a rim, as has been said many times on the call, a rim of bone and something you can get purchase in more immediately, that really is key. That solves a lot of problems because you're going to have a stable base plate. Even if there's a big void in the middle, you can fill that, as far as I'm concerned, with allograft, autograft, whatever you want. If you have stable rim fit of your base plate and stable, secure fixation immediately, especially with the screw-in type base plate, you're going to do okay. Now, if you've got that anterior posterior wall of the vault gone, for me, that's when I go to the iliac crest for sure, because you don't have that structure. You're not going to be able to screw that thing home and get the compression. So I think a lot of good points, but I think this is one where there's a lot of deformity. The anatomy is very altered. And so I wouldn't shy away from getting a patient-specific guide for one of these.
Eric, the other thing that I think we shouldn't leave this topic without mentioning, Mark Frankel has described the alternate center line, which when I first heard it, thought it was BS. It's not. If you take a scapular specimen or a scapular saw bones and you hold it in your hand and you look at the bone quality of the bone that you can drill into, if you just annivert the component 15 or 20 degrees. I used to think that it was going into the scapular spine and there'd be a million scapular spine fractures, but it's not really in the scapular spine. It's in the junction between the scapular spine and the glenoid. And I can tell you that if you're really struggling to find bone, if you just annivert your pin just a little bit, you'll find that bone. And the alternate center line has saved me more than once.
Perfect. I think that's an amazing point to end on. I really appreciate that. Anything else the panelists want to add before we close this out?
Thanks for having us.
Yeah, thank you. Very great. Great job, Eric and Chris.
Bye.
Thank you, Eric and Chris. Thank you.
Great job. Have a good night.
Wonderful, everyone.
Right.
Thank you very much for joining us, and we'll have another one in a couple months. We'll send it out shortly, the announcements on that. But thank you very much. Chris, anything you want to add?
No, great job, Eric, and thank you to the panelists. We had a good time as always, and amazing pearls you gave us all.
Thank you.
Thank you.
Night. Thank you.